Good evening, everyone. Really like to wish you a warm welcome from a rather cold, wet and dark London today. My name's Liz Tomlin and I'm the head orthoptist at Guy's and St Thomas's, and I'll be chairing this session of SOE webinars looking at ophthalmic A&E medicine. I'd like to start with some housekeeping points. We'd really like to make this a very interactive session. So any questions for the panelists, please do put them in the question and answer options, which are on your screen. And also, if they have a particular question after the webinar, do feel free to send it to the email address that's on the screen, and that can be accessed by the SOE website. We are recording this session, so it will be available on the SOE website and placed on our YouTube channel as well. The running order for today is that we will do each talk and then have some questions, and then at the end of all 4 talks, there'll be a chance to ask all 4 panelists questions. We are hoping that this tonight reflects the work of the multidisciplinary team in A&E, and due to that we have a nurse talking about triage, a fellow talking about corneal problems, an orthoptist talking about diplopia, and also a very eminent consultant talking about A&E medicine in ophthalmology. It's a very exciting part of the ophthalmology clinic and very busy and challenging, and certainly an exciting time post-pandemic and during the pandemic as well. So a very relevant part of our clinical job. To get the webinar started, I'd like you to participate in a short poll. There'll be another poll at the end of the webinar as well. But if we just have the poll question up, we can see we'd like to know which region you practice in. And you can see that nearly 90% of us are from Europe tonight, although we do have people not only logging on from North America, but from Asia and Africa as well. So thank you for that. And we'll also just see the demographic of the jobs that have logged on with our second question. And you can see that we have a nice wide range of jobs logged on tonight, mainly ophthalmologists and some residents, but also allied health professionals and a mystery of 8% of other professions, but you're all very welcome. Now, the first speaker tonight is Ian Henderson, who's going to talk about triaging ophthalmic patients. He was rather alarmed when asked to do this in sort of 12 minutes, because he usually does this as a whole day course. He's an advanced nurse practitioner working in a busy A&E department in London now, but he has worked in departments all over the southeast of England. And I look forward to hear what he tells us. Thank you, Ian.
Hello, my name's Ian Henderson, and I've been an ophthalmic nurse for 20 years, and I'm going to talk about triage today. So there's only a few emergencies in ophthalmology. So the immediate ones that we need to take account of are sudden loss of vision, increase in pain, whether in the eye or headache or body, chemical injury or mechanical injury, a sudden red eye, or something systemic. And also the most important thing is duration for these, because if something's been happening for months, it's not an emergency. It should be something fairly recent. So the difference between the service you offer will be different from place to place. Now, do you offer a walk-in service? Is it an A&E service? Urgent care centre, referral only? Are patients able to walk in or self-refer? Do you treat minor illnesses? And that really kind of will make a difference to the kind of what you're triaging, what you accept through the door. And this is where it can make quite a difference between what the patient expects and what service you're offering. Now, the problem is if these two kind of don't coincide, the patient's going to be angry, disappointed, aggressive, and it's important to respond to this kind of that. So if you don't offer a walk-in service, but the patient expects a walk-in service, sometimes you can use a wee trick there, and it's about modifying patients' expectations without telling them off. And you can do that by just saying, are you expected? What time is your appointment? We have an appointment slot at 2 p.m. And this kind of just puts the onus back on the patient. It's saying to the patient, well, do you have an appointment with us? Because that's the service we're offering. And then they will have to negotiate that. But always be ready for the unexpected emergency. You will get patients that don't have appointments and haven't been referred correctly, and this means you will have to assess them to see if they need to be seen immediately. What's a good triage system? Now, a good triage system is something where the assessment's been done before the patient arrives. So ideally, somebody that's referring you should use a pre-assessment form. This should capture the visual acuity, and it would be good if they had the eye pressure, because eye pressures can make quite a difference. If you've got a red eye and you know if the eye pressure's up, you'll want to see that patient fairly urgently. If you've got red eye and no pressure, you'll be, well, maybe this doesn't have to be seen. So pressure's important if possible. Also, documentation of symptoms, duration again, you must have the duration on these things. A basic examination of the eye would be helpful on the pre-assessment form. Pupils, RAPD, ocular eye movements, and possibly a fundus examination or optic disc assessment. Also, if the patient's had previous eye problems and past medical history. These are all very useful for a triage person to know in a referral. Also, I found what's useful is an email address. So an email address staffed by an admin staff, and what happens there is the senior nurse or doctor would kind of look at these kind of referrals that come in and action them, and this is very useful. So you need to have good pathways into urgent clinics and primary care clinics. And this helps with if you're only running an emergency service, it doesn't get clogged up with non-emergencies or intermediate emergencies. So you can refer them into like a corneal clinic or a primary care clinic. It's also important to have a dedicated senior triage person. They can take telephones, assess referrals and walk-ins, and that means they're not getting clogged up with seeing patients and treating patients. This brings us to a bad triage system. So if you don't have a dedicated triage person, you're going to get everything coming in. There won't be any effective triage coming on. Poor levels of staffing, again, who's going to answer the telephone if you're treating patients and you're just trying to get through everything? Junior staff, I would recommend kind of senior staff to do triage. Junior staff, they're not going to kind of be able to sort out any minor illnesses, non-emergencies. And are you having somebody treating minor conditions? Do you need somebody separate to manage this? If you don't have somebody separate, is the triage nurse going to do it? You're not going to have an effective triage. Also, if you have no ability or capacity to refer to urgent or primary care clinics, that means your casualty, your emergency service is going to be clogged up with non-emergencies, things you're going to have to follow up yourself. Now, the two main types of triage system, you've got a diagnostic-based triage system, and these are kind of immediate emergencies. I haven't got time to go into intermediate or urgent, but generally speaking, you have to have a lot of knowledge to use a diagnostic-based triage system. Now, you need to know what giant cell arteritis is. You need to know what central retinal artery occlusion are. You need to know acute glaucoma, double vision, endophthalmitis. You need to know about chemical injuries, orbital cellulitis. This needs a lot of knowledge and training to be able to operate a diagnostic-based triage system. So this slide is about a symptom-based triage system, which is maybe a bit better to use for somebody that's not experienced in ophthalmology, for somebody that hasn't had ophthalmic training, maybe works in main A&E or GP surgery. Now, symptom-based ophthalmology, so it's something like, is there sudden vision loss? Is there sudden increase in pain? Is the eye suddenly red? Now, these are much easier to kind of operate by junior staff and easily kind of interpretable. If you kind of contact somebody experienced with just symptoms, they can understand what you're on about and guide you from there. Any kind of chemical injury, penetrating injury, again, that's very important. Any sudden double vision, any kind of illness, kind of flu-like illness, systemic illness with eye problems, again, very important to kind of highlight. So what about triage? Now, an effective triage, I mean, I've done triage for many years, and what do? Ask. If a patient comes in with sudden vision loss, when did it start? How long has it been? Is it getting worse? Pain, when did the pain start? Where is the pain? Just keep asking details about these symptoms. Is your systemic conditions getting worse? Headache, where is the headache? Is it above the brow, top of the head? Is it worse at any particular time? Is it worse in the morning, the day? These are important. It's important to ask details about the symptoms. So past eye problems are important to know when you're triaging as well. The symptoms can make a big difference. If you've got flashes and floaters, generally that might just be a posterior vitreous detachment. But if somebody says they are high myope, have previous retinal detachment, that's going to make your decision a much more acute. That's definitely something that needs to be seen fairly quickly. If they're not an emergency, always double check. Some patients aren't great at communicating, so ask again. Why are they attending? What's brought them in today? Has anything got worse recently? You don't want to miss something just because somebody can't communicate. If you decided they're not an emergency, there's no need to do the vision. Some people say you should all do the vision. Why? If you're not going to treat them, or if you're only redirecting somebody to another service, as long as you haven't interfered with the vision, you just document you've not done a formal assessment and you've pointed them in another direction. And always remember, check the pupils. Pupils are a very, very good sign in ophthalmology. If something's irregular or dilated, fixed, that's very important. It could make a big difference. So if you look at just one example, a sudden loss of vision, this is a central artery occlusion. Always needs treatment within 2 hours of the symptoms. There's not much research on it, but it's a sudden painless loss of vision, white eye. Vision often count fingers, hand movements, perception of light, and you'll have a positive RAPD. You may have a history of kind of transient vision loss. Treatment, well, again, there's not much research there, but we generally kind of try and increase the outflow by ocular massage, CO2 rebreathe for vasodilation, urgent transfer. If you get a phone call with somebody with a sudden loss of vision and it's been 2 hours, tell them to breathe into a paper bag and massage the eye. It could make all the difference to the vision coming back. What's more important, prognosis is often very poor with these patients, but it's more important, it's this systemic condition. Why has this happened? Are they going to have a stroke? Check the blood pressure, check the bloods, and carotid Doppler maybe. It's a very poor prognosis though. And then our famous one, an acute angle closure glaucoma. Now with this, you've got brow pain, you've got blurred vision and nausea. Sometimes it can be missed as another practitioner might be treating them for nausea and vomiting and headache, and actually it's all coming from the eye. You can see here, this is a typical acute angle closure, red eye, corneas hazy, pupils dilated, and they'll have forehead pain and brow pain above the eye that's affected. Other kind of sudden loss of vision, you can get vein occlusion, optic neuropathies, vitreous hemorrhage, retinal detachments. Some of these are not, you don't necessarily have to do immediately, but certainly they need to be seen the same day if the vision is affected. A sudden increase in double vision. Now, I've just put a picture of a kind of traumatic one here, but neurological kind of issues would be more important. So third nerve palsy. But when you're assessing somebody's double vision, it's very important to know if it's monocular or binocular. That will save a lot of hassle. So if you cover this gentleman's eye, if you cover either eye, their double vision will disappear. If it's monocular double vision, the double vision will stay depending on which eye is affected. It could be both. So double vision should disappear if you cover an eye, and it's binocular double vision. And it's far more urgent, binocular double vision. Chemical injuries. Now, the most important thing about chemical injuries are, first of all, did they ingest or inhale anything? That's the primary concern, because any kind of workplace chemical injury means there is a high risk of ingestion and inhalation, and that would need to be treated first. If there was any airway problems, they may need to go back to A&E, they may need to go to intensive care. It's important to know how long ago it was and how much irrigation was done. Was it alkaline or acid? And you can see in this picture there's a white patch, which means there's bleaching. So these kind of vessels have become ischemic. Ischemic vessels are a bad sign in a chemical injury. And here we have a picture of a red eye. So red eyes are sometimes the most difficult to diagnose. And this means history becomes very important. Is there photophobia? Is the other eye red? Any sign of upper respiratory tract infection? Any headache? It could be anything, a red eye. But one of the most important things are photophobia, and is the pupil irregular, dilated, and that's gives you a very good sign of what's happening. And then here's another kind of red eye with a kind of dilated pupil. Looks like this has been happening for some time, but it certainly kind of highlights the kind of point that you must check the pupils, and that gives you a good sign of what's going on. One other thing is just don't be distracted by red herrings. So I had a patient that came to me. He was doing some bathroom renovation, putting some ceramic tiles up. He came in and said, "Oh, I've got to put ceramic tile in my eye." I looked at the eye. It's like certainly had a kind of localized area of kind of fluorescein uptake, and I'm like, "Oh, but there's something else going on." The blood vessels were a bit dilated. He had a bit chemosis. It didn't sit right with me, so I was I had to be a bit careful because the patient was telling me one thing, and when I looked at the eye, it was telling me another thing. So I kind of had another look, and I noticed he had a proptosis. So he ended up having an AV fistula. So patients that come and tell you a story, you have to be a bit careful. Careful of them self-diagnosis. You may have a lot of patients that come tell you they've got an infection. We're not treating diagnoses, we're treating symptoms. It's important to know what the symptoms are rather than the diagnosis. And that's my presentation finished. I hope you enjoy it. If I could recommend that, actually, if you want to learn triage properly, it's going to take more than 12 minutes. So you need to spend a good day doing triage. Okay, I hope you have a good day today, and thank you very much.
I thank Ian for that talk. At the moment, we don't seem to have any questions particularly for him, but I have Seema joining me, and I think the value of a good triage nurse really can't be underestimated when you're running an A&E department. From my point of view, the problem that the patients attending have is whether they've actually got a brain tumour or blepharitis. They all believe it's a brain tumour and are equally worried. And a good triage nurse is worth their weight in gold.
Totally agree, Liz. I think triage is a really, really important aspect of running a good emergency service. And I think Ian has has pointed out the very important things like taking a good history, not being distracted. And I think we all know, and we've all seen probably, somebody who has a chalazion is equally worried to a patient who comes in with sudden loss of vision, because they all think they're going to lose vision. And we have to be very sympathetic to them. But of course, we also have to look at what our workload is, and that the patients that require immediate treatment aren't delayed as a result of, accepting everybody.
Yes, I would echo from the patient's point of view, a good triage can be reassuring, but also from the doctor's point of view, a good triage nurse can actually be an excellent gatekeeper, so that you are using your time seeing the patients that actually need to, and they can discharge to the relevant person, maybe an optometrist, or even just giving good healthcare advice, and actually reassure the patient and save the consultant a lot of time when they're actually within a busy clinic. So again, really well worth investing in their education and them as part of the multidisciplinary team. Right, as we've finished Ian's talk, we're now going on to think about the work of ophthalmic fellows. And I'm very delighted that we've got Luis Garcia Aruba representing Spain for this talk. and he's going to talk to us about the challenges of anterior segment ocular emergencies. I think probably corneas are one of the most frightening things to see in casualty and often very demanding. So thank you, Lewis.
Hi, my name is Luis Garcia Onrubia, and first of all, I wanted to thank the European Society of Ophthalmology for the invitation to be part of this series of webinars. Currently, I'm doing a cataract and corneal fellow at St. Thomas Hospital, and today I will try to summarize my personal experience around corneal pathology in the emergency room. We must bear in mind that in hospital-based emergencies, ophthalmological emergencies are a significant component. Conditions related to the ocular surface comprise up to 45% of the ocular emergencies. They encompass a very broad group of pathologies. Therefore, we cannot go through all of the pathologies in just 12 minutes. So I have selected those that are more frequent. We will start with corneal foreign bodies that are the second most common form of ocular trauma, which with corneal abrasions being the number one. Although the cause of corneal foreign bodies is very wide, there are two that personally make me alert. The first one, when the patient has been hammering, since particles released during this activity have a higher temperature and a greater inertia than in other activities such as polishing. Therefore, the risk of having a self-sealing wound that can get unnoticed during the examination, if we are not aware, is very high. For instance, in this case, they found an intraocular foreign body that was missed during the first examination. The second one is when patients who has been driving or walking notice something going on their eyes. I have seen some crazy cases during my training time in Spain. For instance, in my third year as a trainee, I saw a patient who was taking a walk in a bike and noticed that a leaf came to his eye. He ended up with a fungal infection. I think that all of us know that a thorough and meticulous slit lamp examination is needed. You have to write down all the details, the positive and negative signs, explore the fornices, and to be sure that the serial is negative. At any point, if we found any sign of possible intraocular foreign body, a dilated fundoscopy exam and a CT image should be mandatory. The treatment, as all we know, pain control, remove the foreign body, and prophylactic antibiotics. Now we will talk about the chemical burns, which are one of the most frequent causes of occupational accidents. It's important to know that most of them could be prevented with the use of protective glasses. So labor education should be one of our weapons to combat this pathology. Although in recent years, a change has been detected in the pattern of presentation, with a significant increase in assault-related chemical burns. Men are more frequently affected than women. And something that I would like to point out is the chemical burns in children that are frequently related to household cleaning agents, and most of them could be prevented. The caustications can be caused by acids or alkalis. The acid caustications are less frequent and produce more limited damage, being the most common one the sulfuric acid. However, some acids have a high capacity to generate serious damage, such as the hydrofluoric acid, which is an agent used in several industries and has a extreme ability to penetrate into the anterior chamber. On the other hand, the alkaline substances are the most common cause of chemical burn, with a higher capacity of creating a severe damage in the eye. Of note, ammonia has the fastest penetration rate and a high capacity of perforating the cornea. There are two main classifications, the Roper Hall and the DUA. The Roper Hall classification is an important classification system of accurate prognosis, being simple to follow and used in several clinical trials. A weakness of this classification system is that it doesn't take into consideration the conjunctival injury, which has been shown to be of value in predicting prognosis for corneal maintenance and symblepharon. The other classification, the DUA, has been developed to enable more accurate stratification prognosis, particularly for severe injuries. A key difference between one and the other is that the Roper Hall classification relies on the presence of perilimbal ischemia to assess the limbal stem cell injury, while the DUA requires the presence of fluorescein staining on the limbal area. I think that we all know that the first thing to do facing an eye caustication is to irrigate and clean, taking a special consideration in removing all the material from the fornices. The goal of the acute treatment is to stop the inflammation, halt the epithelial and stromal breakdown, and promote epithelialization and stromal healing. One of the main problems of the chemical advance is how to manage the late and chronic complications, such as chronic epithelial defects, glaucoma, limbal cell deficiency, and so on. With this purpose, different strategies have been tried, such as the use of autologous serum or amniotic membranes for the acute management. But sometimes, despite of all of our efforts, the limbal cell transplantation or even corneal transplant may be necessary. Now, we are going to talk about microbial keratitis, which can be one of the most frequent conditions seen on eye casualty and represent a real diagnostic and therapeutic challenge due to the wide range of organisms that can produce this pathology with very similar presentations. It's more prevalent in patients with alterated ocular surface or who present some additive risk factors, such as the use of contact lenses. It is important to highlight the use of contact lenses as one of the biggest risk factors. In addition, the cause of this pathology will vary depending on the characteristics of the population that we attend. So patients with contact lens wear are more prone to bacterial infections. Patients with high-risk professions such as farming or agriculture, they are prone to have fungal infections. What are the risk factors? So epithelial defect, as all we know, is a risk factor for microbial keratitis. Contact lens wearer, we cannot forget about asking the patient, are you a contact lens wearer? It's something very important. Ocular trauma, we cannot forget that surgery is an ocular trauma. Even refractive surgeries are ocular trauma. Systemic conditions, such as pemphigoid, for instance. Ocular surface disease. I have seen several patients during the last month with descompensated cornea due to complicated cataract or fused dystrophy, who come to clinic with microbial keratitis. The clinical history is going to be one of our main tools. It's important, for instance, if we see a patient with a hyperacute microbial keratitis, to think about Neisseria gonorrhea as a possible cause. In patients with normal epithelium, Pseudomonas or pneumococcus could be the cause. Ask about the contact lenses. Ask about ocular traumas or any ocular surface conditions should be taken into consideration. It's very important to write down all the details of the slit lamp examination. What is the cornea? How is the cornea? What is the epithelial defect? Are there fibrin? There is hypopyon. And it's important to do as well at the end of the scrape. Don't forget about the corneal sensitivity. It's going to give us information about possible herpes. And one of the big question is when to do the corneal scrape. We had a chat yesterday with one of my consultants about this topic, and we ended up agreeing that a corneal scrape should be made as long as there was no very good reason not to do it. So in my opinion, and after my experience in the last months, we should always make a scrape in exceptional cases. Antibiotics. We have a full range of antibiotics, and one of the biggest questions is if the use of monotherapy or combined therapy as the first line treatment. In this study, they investigated what is done in real cases, being the combination of vancomycin and tobramycin and the monotherapy with a fluoroquinolone, the two main strategies. Daily, for microbial keratitis, I usually use fluoroquinolone as a first line treatment. Another topic is the use of anticollagenasses such as the doxycycline, which can be used in corneal melting. Last but not least, the use of corticosteroids has been a matter of controversy. As a rule of thumb, I will not recommend use them on eye casualty, and I think previous using them, we have to have a discussion with the corneal service. But be cautious, bacteria are not alone. There are other microorganisms such as acanthamoeba, fungus, herpes, or mycobacteria that could mimic or could be the cause of microbial keratitis. Acanthamoeba was first described in 1974. There was a sudden increase in the number of cases due to contact lens wearers in 1984. As all we know, they are related with contact lens, but as well with ocular trauma with exposure to soil or contaminated water, and people with chronic use of steroids. The main problem with this pathology is the clinical signs mimic other pathologies. I would like to point out the perineural infiltrate as one of our red flags to think about acanthamoeba. So if we have a patient with contact lens keratitis and a lot of pain that doesn't correlate with the clinical signs, consider yourself warned that could be acanthamoeba. The treatment course of acanthamoeba is often long and challenging, and recently monotherapy with PHMB has been shown to be as effective as combination therapies. The use of steroids in the treatment of acanthamoeba remains controversial and should, in general, be used with extreme caution. I think that not in high casualty, and it has to be discussed with the corneal service. Another main thing is to know what is the best dose of PHMB. Several studies are now in process to find out that question. Regarding fungal keratitis, we have to know that this is an important cause of blindness, being more frequent in tropical and subtropical areas. It's mainly related to plant trauma in these locations. However, in our population, it's more related with the prolonged use of ocular corticosteroids or in contact lens wearer. All we know, all the risk factors about fungal keratitis and the clinical signs. One of the signs that I would like to point out is the satellite lesions. This is one of my first cases as a trainee when I think it was my first on call of this keratitis. We did a scrape with the a confocal microscopy, and we found out that there was a fungus. She ended up with a corneal transplant. The diagnosis is very important to have in mind the clinical signs. The confocal microscopy could help us during the diagnosis, but the corneal scrape and corneal biopsy is our gold standard. Regarding the treatment, we have a wide range of options. Prior to the development of natamycin, the most commonly used antifungal was amphotericin B, which is still used today alone or in combination with natamycin, with relatively good results. One of the last studies, the mycotic ulcer treatment trial, found significantly better visual acuity at 3 months in patients with randomized to receive topical natamycin compared with those randomized to receive topical voriconazole. So natamycin could be one of our first-line treatment in infections by Fusarium or Aspergillus. And last but not least, I would like to show a video of a corneal perforation where the use of corneal glue was very helpful. It is something that we are not used to doing every day, but that can be helpful in emergency situations. This can be performed in the slit lamp and the topical anesthesia using a needle to debride the epithelium and draw the perforation, and absorb a microsurgical sponge to dry the area in which we are going to apply the glue. As we can see in the video, we dry the target area, and now we can use the glue. Thank you so much for your attention. And if you have any questions, just let me know.
Well, I'll thank Lewis for that very useful talk with rather beautiful pictures and videos. Unfortunately, he is really living the life of A&E emergencies, and I'm afraid he's just being called away because he's on call. So I'm very happy that Seema will step in and answer any questions. It seems that most corneal things really do need to see a consultant. Do you think that's true, Seema?
I think it depends on the level of training of your junior doctors in casualty. I think one of the things I feel is really important is, for example, I'm sure every unit will have their protocols, you know, what to do when you see X, Y, and Z. So one of the things, for example, as Lewis was saying, if you have somebody who comes into casualty and they have a lesion that looks like herpes simplex, you know, they've got a dendrite. And if you've never asked the question, are you a contact lens wearer? You'll never think about acanthamoeba as something to worry about. So initially, I think it's the training and basically the nurturing of your multidisciplinary team. You know, once you've got that in place, of course, if there are things that they cannot deal with, then you have your senior doctors to come and help you. And I think one of the biggest things I would say to everybody who works in a casualty department, be humble, be ready to ask anybody that you think will help you deliver good care to your patient.
Excellent, thank you. Just one question from me. Lewis alluded to chemical burns in children. Now, are there any particular signs that I should look out to see if this is a safeguarding issue, or is it always a safeguarding issue, or are there key things that I should think about when I see children with chemical burns attend?
Excellent question, Liz. I think that, again, here, the history is very important. Because sometimes you get injuries that are actually agreeing with the history, but there may be times you'll see clinical signs that don't actually go with the history. And I also think, depending on the age of the child, the body language between the carers, the parents, and the children. And I know that we are ophthalmologists and we deal above, you know, as they say, above the belt. But I think one really needs to, if you're worried, I think if you have the slightest bit of doubt that this is a safeguarding issue, you must contact your safeguarding team, and you must take every opportunity to look at the child's body. For example, are there bruises? Are there cigarette burns? I mean, one's seen horrible things. And one must be alert, and one must seek help. Very good question. Very, very good question.
Thank you, Seema. Now, the next speaker I have the pleasure of introducing, which is slightly weird because it's myself. So my talk is about diplopia, when to worry, and I will be back to answer any questions. So do feel free to put them in the question and answer section. Thank you. Thank you very much for asking me to speak at this webinar tonight. And I'm going to be talking from the orthoptist's point of view, supporting a busy A&E. And we're going to think about diplopia, when we need to worry. The first thing to do is think about when a patient arrives, do they have monocular or binocular double vision? And this is usually easily done by testing, looking with both eyes open and then under monocular viewing conditions. And you may get monocular diplopia in patients who have cataract, corneal, or macular problems. And these are the ones that we're not thinking about tonight. I want to think about the patients who have binocular double vision. Now, taking a good history is absolutely vital. And it may well be that the patient gets double vision immediately after they've had some trauma, maybe been in a road traffic accident or a fight, or it may be that they can say they have no understanding of why their double vision has occurred, and it's come on either very suddenly or of a gradual onset. And this is very important. If the patient knows exactly the time, maybe when they were watching their favorite television program, that they suddenly got double vision or they woke up with it, we'd describe this as a sudden onset. And this is often thinking about a vascular cause. If they have a gradual onset, then this could easily be the growth of a space-occupying lesion, giving them a problem, and getting gradual double vision, which is increasing. There are, of course, a group which are variable, and this can be decompensation of aphoria or a variable disease, such as myasthenia gravis or thyroid eye disease. Myasthenia typically much worse in the evening when the patient is tired, and thyroid typically worse in the morning when the patient's lain flat overnight and their muscles have become engorged. Now, we've already spoken about sudden onset, and one of my direct questions to patients with double vision from casualty is, do they have hypertension or have tablets to control their hypertension? Are they diabetic, or are they on a statin or have high cholesterol? Some people, when they're actually being treated for a disease, don't consider they have it anymore. So it's very important to ask both whether they have the condition or they're being treated for it. And these are our groups that we, if they have a sudden onset, gives us some comfort that we are probably looking at a vascular problem. The next question I'd like to ask is the patient above or below 60 years old? And if they are of sudden onset but under 60, we still can consider a vascular cause, but it may also be demyelination or a change and increase in intracranial pressure or something such as an Arnold-Chiari malformation. In over 60s, if they have a vascular risk factor such as diabetes, hypertension, or high cholesterol, then our threshold for actually actively investigating these patients is much lower. So the next thing as an orthoptist is to look at eye movements. And here I'd be looking at a cover test for near and distance, considering that if you have an esotropia, which is worse in the distance, it's often a sign of a 6th nerve palsy. And very carefully examining ocular movements, including fast eye movements, saccades, and vestibular function if we think there's a supranuclear squint present. The other part of my job at this point is to carefully measure the eye movements, and this can be done with prisms or a Hess chart, and then making the patient comfortable. So if they have walked into casualty with double vision, we want to use a prism to relieve their double vision or move their eyes and single vision into a useful area for them. And if this isn't possible in a very incomitant squint, then using occlusion is often very useful. Now, I'd like you to look at this first video of me. It's a young girl, so she's under 60, and we would be thinking that we need to investigate her double vision. And she's complaining that she gets blurred double vision when she looks to the side. Now, if we look at her eye movements, when she looks to the right, she buries sclera on both sides, and this looks okay. When she looks to the left, you can see that she's not burying sclera on her right eye, and her left eye has nystagmus in it, an AB ducting type of nystagmus. And on elevation, she also has some gaze holding nystagmus. I want you just to watch that again and look at her nose as you're actually looking at her eye movements. This will mean your cones are fixed on her nose, and your rods can see the movement of the eye and how disjugate that eye movement is. She's getting double vision. She's also getting oscillopsia. And that's a limitation of adduction with abducting nystagmus. So we're thinking that this is a right INO. And when she elevates her eyes, you can see that she's got that gaze holding problem. I find that very useful because we know an INO is a lesion in the medial longitudinal fasciculus. But if she has that gaze holding nystagmus, it's much more likely to be a true lesion than a lesion that is due to myasthenia gravis, which can mimic this condition really rather well. I've already said I like to examine saccades in eye movement cases. And here you can see when you look at her horizontal saccades, how disjugate that movement is and how she's getting a slow adducting saccade and a very hypometric saccade in her left eye, depending on how the nystagmus is. And you can see how disorganized this eye movement is to her. This is one of the eye emergencies that I am always on the lookout for. This lady came into casualty and she said she had got a bit of double vision, but that had gone now because she had a ptosis. She was complaining of great pain, and that's not the sort of pain where you think a slight headache. These people often complain that they have power tools in their heads. And you can see from the picture here that if we lift her ptosis, her eye is classically down and out with a large pupil, and she has a third nerve palsy due to a posterior communicating artery aneurysm. So we would do an MRA on the same day in our hospital, but the imaging you use depends on the neuro center that you're at and what you can get. And if we look at the angiogram here, you can see there is the aneurysm, and in 3D reconstruction, it's really rather beautiful and showing there. So when we're confronted with someone with double vision, if they're mainly saying it's horizontal, you can think about INOs as we've seen, but also 6 nerve palsies and gaze palsy problems. And in vertical, think about 4th nerves, 3rd nerves, dorsal midbrain syndrome, and skew deviation. This is one of the conditions that often catches A&E and orthoptists out, and it's myasthenia. This patient actually comes in and presents rather like the lady we've just seen with the third. She has double vision, she has ptosis, but she has a very variable pattern, which makes us think of myasthenia. Remember, this can be variable on a day-to-day basis or a minute-to-minute basis. And if we put some ice in a glove and put it over the eye for about 2 minutes, this has a dramatic effect on myasthenia. Whereas if we just rest her eye for a couple of minutes, there is not such an improvement. In fact, she's almost practically the same. So this is a positive ice pack test for myasthenia, and is very useful when you're trying to find out if the eye movements are due to that. Had a sudden onset of horizontal double vision, and you can see that that's due to her 6th nerve palsy. In the primary position, she has a small ESO. When she looks to the right, she has no double vision and she looks okay, but on left gaze, she's got a -4 limitation of her abduction and her lateral rectus. And she was known to have high blood pressure. She was over 60. And so we thought we wouldn't actively investigate her. We sent her back to her hypertensive physician to say that she may need some help with that. And we did an ESR to think about temporal arteritis, but that was negative. We fitted her with prisms and we saw her in 6 weeks. Now, it's very important with these patients that they actually start to improve within 6 weeks if you've given them the label of vascular diplopia and vascular 6. She had no improvement, and so we did investigate her, and actually her 6 was due to a meningioma in her cavernous sinus just behind her left eye. And the reason it had come on suddenly was she just bled into that. So it was a vascular event, but we needed to drill down when she didn't get any better to find her meningioma. So I'm thinking that actually when a patient comes to you, if they are under 60 with double vision, you really need to think about investigating them, particularly if they don't have diabetes, they don't have hypertension or high cholesterol. And this would involve looking at their discs and scanning them and thinking about multiple sclerosis, maybe myasthenia, space-occupying lesions. And we know that sadly, 6 can come on from secondaries from breast cancer in young ladies, for instance. So a real proper investigation to why they've got their double vision is important. If they are over 60 and actually have a risk factor, then we would, like the previous lady, investigate in 6 weeks' time if they hadn't improved. I hope this gives you a guideline of when to worry when diplopia arrives in your department. Thank you. I'm so sorry, I have just joined because the my internet went down, which is an absolute nightmare. Are there any questions for me?
May I ask a question?
Of course, Seema.
What would you do if, say, you had a patient that came in the middle of the night and under 60 with sudden onset of diplopia? And the reason I'm asking this, Liz, is that that's usually when they come, you know, in the middle of the night. So what would you want the junior ophthalmologist in the department to do in terms of investigation and stuff? Should they wait till the morning? How would you proceed? Just a guideline.
So they're under 60 and they've got a sudden onset of double vision. It's really about the history and, as Ian said, talking to the patient, because they may well have signs and know that they have breast cancer, in which case putting a patch on and actually reassuring them and then getting the investigations in the morning, but also looking at discs and checking that there are no other signs, checking that it isn't actually an emergency. You know, the third with the pupil and the pain is the one that always makes us go, we must do a scan now because we really can save a life with that. But actually looking at the discs, checking that there's nothing else in the history, and then probably arranging bloods and a consultant opinion and getting the eye movements and the actual diagnosis in the morning is probably going to be good enough. There's very little other than the third nerve palsy with the pain and the pupil involvement that really makes my heart sink. Obviously, we see terrible things in eye movements and onychiari and supranuclear problems, but actually they can wait a couple of days. And actually, if you haven't got time to put on a proper prism, actually just reassuring the patient and giving them occlusion so they can function for the next 24 hours until someone's in on the Monday is probably acceptable. I don't know what you think.
No, it's absolutely what we would do, but it's always nice for the delegates just to hear, because it is a time, in my experience, I think it's when we panic. It's the neuro patients, I think, that makes us as ophthalmologists panic, because, you know, one's always worried, oh my goodness, something sudden is going to happen. So thank you.
Okay, it is now my pleasure to have our last speaker, and this is back to Seema. Seema is a consultant who's really pioneered A&E in England as an actual ophthalmic specialty, and thus leads our Royal College of Ophthalmologists wing in A&E medicine. And I'm delighted that she can join me today to think about what she would get out of bed for in ophthalmic emergencies. Thank you, Seema.
Good morning, ladies and gentlemen. First and foremost, a very big thank you to SOE for their kind invitation to do this talk. Now, many things present to the eye casualty department, but we don't get out of bed for all of them. And so what we have to do is try and find a system by which we recognize what is important. So how urgent is urgent in ophthalmology? What are you going to get out of bed for? One of the ways to look at it would be to divide things into sight-threatening or life-threatening problems. And some of the things that cause unilateral sight-threatening problems are conditions like acute angle closure glaucoma or endophthalmitis. Bilateral sight-threatening problems could be things like uveitis or acute loss of vision from giant cell arteritis. And then we have things that are not only sight-threatening, but also they're life-threatening. So, for example, a third nerve palsy from a cerebral aneurysm, or an endogenous endophthalmitis in a patient that's a drug abuser. Now, if we look at what the reality is in terms of what comes in to the hospital, we did an audit at St. Thomas's Hospital looking at the top 10 sight-threatening conditions. And you can see that our top 10 is not that different from the published top 10 by the Mayo Clinic. And I'm sure that it's not that different from what you see in your units. So amongst them, acute angle closure glaucoma, endophthalmitis, orbital cellulitis, retinal detachment, retinal artery occlusion, giant cell arteritis, chemical injury make up the bulk of the presentations. So I think the way to decide whether you're going to get out of bed or not is around looking at pattern recognition. Okay, the eye can only tell you in certain ways that it's not well. It can become red, it becomes painful, the vision decreases, or it develops double vision, or there may be a combination of these things. But it's the history. It's the history that will tell you whether something is important or something is not important for you to get out of bed in the middle of the night. So the history, the examination, and then you've got to have a differential diagnosis. So pattern recognition. Let's look at pattern recognition. Eyes can present with either sudden loss of vision or gradual loss of vision. And these things can be painful or painless. And that's one way that you can look at the whole system. And here on this slide, I've put down some of the things that cause painless loss of vision and some things that cause painful loss of vision. And then you've got anterior ischemic optic neuropathy that can do both. And it's the history that will tell you whether it's non-arteritic or it's arteritic. So let's start with ocular trauma. Now, you'll see a lot of this for which you may need to get out of bed for, and they can be divided into high impact or low impact injuries. And they can cause hemorrhage, orbital wall fractures, globe ruptures, lacerations, and of course, they can present as chemical injuries. Now, in this 10-minute talk, I can't go through all the things, but I thought I would talk about retrobulbar hemorrhage. This is an emergency. There's no time to investigate in terms of, shall we do a CT scan? Because the problem is the optic nerve is at risk and you are at losing that patient's vision. And so it's the history of trauma, and then the signs, the clinical signs, a poor vision, an eye that is proptosed, a tense orbit, and of course, the presence of an RAPD. If you have this, I think you need to perform a lateral canthotomy well before you start to do any kind of investigation. The other emergency, which is not only an eye emergency, but also a medical emergency, is central retinal artery occlusion. Now, central retinal artery occlusion will present with profound, sudden, painless loss of vision. And again, when you examine this patient, you may find that they're diabetic or they suffer with high blood pressure, and that they have an RAPD and very poor vision. When you look into the eye, you may find a cherry red spot, a retina that looks very pale, and you may even see the presence of emboli. And the treatment involves reducing the ocular pressure. And the other important thing is that these patients need to be referred to the stroke unit, as this could be a presenting sign of a stroke. Now, one of the presenting features of giant cell arteritis can be a central retinal artery occlusion. So giant cell arteritis usually affects people who are older than 50 years of age. And most of these patients will present with a history of a headache, they've not been well, maybe there's been weight loss, there's scalp tenderness, so when they brush their hair, their head feels sore, there may be jaw claudication, they may have proximal weakness relating to polymyalgia rheumatica, or they may present with profound loss of vision. And again, there may be reduced color vision, there may be an afferent, you may see a central retinal artery occlusion, they may even present with a cranial nerve palsy and present with diplopia. And the investigation is urgent ESR, and the treatment is high dose steroid. And this can be oral, it doesn't have to be IV, but it needs to be given promptly, because if you don't, these patients are at risk of losing not only the vision in the affected eye, but soon the vision in the unaffected eye. Once that has been given, then you can think about temporal artery biopsy, and if you have access later on to an ultrasound, you can ultrasound the artery. The most devastating for all of us is post-operative endophthalmitis. And so these are patients that develop infection post-intraocular surgery. And they present themselves with sudden onset of rapid and progressive loss of vision, pain, and redness of the eye. And again, the examination can vary from slightly reduced vision to profound loss of vision associated with lid edema, conjunctival chemosis, a purulent discharge, a poor red reflex, and as you can see in this picture, a hazy cornea and a hypopion. The treatment, of course, for these patients is aqueous and vitreous sampling pretty quickly, and followed promptly by intravitreal antibiotics. Now, all your units will have their own protocols, which you need to get yourself familiar with, but prompt treatment is what needs to be done. You cannot delay this, because the more you delay, the worse the prognosis for these patients. The other emergency for eyes is acute angle closure glaucoma. So here, patients will present with sudden, painful loss of vision, and most of these patients will be in a lot of pain. Some will be vomiting as a result of the raised intraocular pressure. And people that we see this condition in are people who are hypermetropes. and the cornea will be hazy, the pupil would be mid-dilated, the eye will be very red. And the treatment is to reduce the pressure, to get that intraocular pressure down with intravenous Diamox and topical antihypertensive treatment. And before the patient leaves your unit, a peripheral iridotomy, not only to the affected eye, but also to the unaffected eye, as that eye also is at risk of developing acute angle closure glaucoma in the future. Finally, orbital cellulitis. Again, this is an emergency because if it's not treated, the vision goes because of the damage to the optic nerve. So how do these patients present? Sometimes they will present with a preseptal cellulitis, which can then become orbital cellulitis. So they will present either with a history of a cold or a cough, or they will present with pain, lid swelling. And although the lid is swollen, it is our job to open that eye and look at the eye. Is the eye red? What's the motility of the eye like? What is the vision? Is there a presence of reduced color vision? Is there a presence of an RAPD? All of which is telling you that the optic nerve is vulnerable. These patients require prompt IV antibiotics. And again, your units will have the protocols that you will follow. These patients require CT scans of their sinuses. And you need to involve the multidisciplinary teams, such as the ENT team, and if it's a child, then the pediatric team, because this it requires a multidisciplinary approach to treat the patient. So that was a whistle-stop tour of why I would get out of bed and why you should get out of bed for ocular emergencies. And again, I'd like to thank SOE for their kind invitation, and I hope you enjoy the rest of the session. Many thanks.
Thank you very much, Seema, for that very enlivening talk. Luckily, as an orthoptist, I don't usually have to get out of bed for very much, but my heart goes out to the ophthalmologists that do. We don't have any questions specifically for you on that session, but we do have quite a few that I think you may be able to help answer about the sessions as a whole. Can I also invite Lewis and Ian to join us for the end session? So if anybody does have any questions for us, please do put them in the questions and answers. The first question is from William Seller, who's asking, saying that myasthenic patients often have bulbar problems, difficulty in swallowing and choking, shoulder ache and headache due to holding their head up, and often unsteady gait. And I would completely agree with this. I think the patients I was talking about in my talk are the ones that just have ocular myasthenia before they are generalized. And I think these are a very difficult group to sniff out because often they just have a little bit of intermittent double vision. They can mimic an INO, they can mimic a cranial nerve palsy. And of course, it can be a variable squint that they present with from either the beginning or the end of the orthoptic assessment, or actually the beginning and end of a month or a week. So I think that was the ones I was talking about, not the actual generalized, who obviously have difficulty with swallowing. The next question talks about how you tell a decompensating phoria in an eye exam as against a neurological cause of diplopia. And I think this is a very interesting question. Often neurological causes for double vision have very little on cover test when you look at them, but a decompensating phoria will actually show itself on cover test in the primary position often. For instance, an INO can have a very small exophoria, but quite a big distrugate movement. A phoria can also, if you measure it and it is decompensating, the fusion range is often just on the cusp of controlling it. So when it's a nice, bright, sunny day, a patient with a large exophoria has a slightly larger fusion range and they can control it if they're well rested. But if they're actually getting over the flu, they're feeling tired, it's a grey day and the children are misbehaving, their fusion range goes down a little bit and they get their double vision. So I think actually looking at the primary position, thinking about how much fusion the patient has, and if the eye movements are conjugate and the same phoria in all positions of gaze is very useful. I don't know if you'd like to comment, Seema.
You're the expert. We go to you, Liz. So that's absolutely right.
Well, maybe this is one you can help with. Somebody's asked, would you scan a person older than 60 years with diplopia who has no vascular risk factors? I think I'd definitely do an ESR, and I think it depends on the onset. If the onset is still very quick and they know exactly when they happened, it's probably still vascular. So maybe we should test them for hypertension, which of course can be high at only certain times in the day, diabetes or high cholesterol. And then also the history. But if none of those are present, yes, I think we would investigate these people thoroughly. What do you think, Seema?
I think I agree. I think sometimes there's a tendency to over-investigate as well, you know, and so one's got to be careful. But as you say, if there are no risk factors, then I do think that we would all be saying, well, you know, what is the cause? We've got to look a little harder.
Excellent, thank you. Now we have one last question, and it's about a specific patient, and it's a case of intermittent binocular double vision. I think, yes, it's an esotropia and an esophoria, and it's a gradual onset of a year. The patient's been investigated for myasthenia and thyroid, and this has been excluded. So what are we thinking about? Does anybody want to help out on this one? Okay, I'll have a crack then. Yeah, I think the most important thing is to ask if the patient is very short-sighted or over -5, probably more like -10, because then they can very easily have a distance esotropia, which is associated with their myopia and then not a sixth nerve problem. You really want to think about whether they have got lateral rectus, because of course, what I'm worried about here is the slow growing chordoma that just very slowly and insidiously gives a sixth nerve palsy, and looking for an MRI scan just to look for that, as well as other things that can give you that ESO problem. Seema, do you want to add anything?
No, I really don't. As I say, I think that what is really important is to involve the multidisciplinary team. And of course, people like yourself, Liz, being an orthoptist, you know, this is your bread and butter. And sometimes we struggle, you know, well, what's going on? And as I said from the beginning, be humble and just ask and say, please, I can't quite put everything together, but I know there's an abnormality here. You know, do we need to do something? So I definitely think things in the casualty department that pertain to neurology, you know, are very difficult for us.
And having good links within hospitals and good pathways to that neurological team when you need them, and the Corneal team, as we've seen tonight, is worth its weight in gold. Are there any more questions for the whole panel, or any questions from the panel to other panelists? I'm very aware that it's only me between you and your weekend. So what I think we ought to do is thank the speakers very much for their expertise and a really entertaining webinar tonight. Thank you for that. Thank you to the audience for giving up your time on a Friday night, and particularly the members of SOE that have made this webinar happen. It doesn't just happen by magic. There's been a lot of hard work from the team with Joe, Hannah and Anne, and thank you so much for the people at Talking Slides for making the magic happen. Today's webinar will be on the SOE website very shortly, and I would really like to wish you a very happy and healthy weekend. And there are just 3 questions that we would very much like you to answer on leaving the webinar. So thank you very much for your time, and it seems appropriate to leave you with a Zoom wave and hoping that we can meet face to face very soon in the future. Thank you.